then. Sala još malo popuna. Dobro, može? Ok. Good morning everybody, dobro jutro svima. It is my great pleasure to welcome the representative from the International Society for Vascular Health, SVJETSKI and Hispa, as Girard spoke yesterday, has been collaborated 8 years now. And this is actually, I think, 10th or 11th Congress together, both in Serbia and Bosnia. And we have actually 2 sessions. One session is strictly SVJETSKI and Hispa now, and the second is in collaboration with the Hispa Bosnia. So, 2 distinguished professors will chairing this session. I would like to announce Professor Dr. Uven Cimlichman from Tel Aviv, Israel, and Dr. Žira Topusyan. He is from all over the world, but at the moment he is in Paris. Really. Dobro jutro svima. Hteo bih da najavim sesiju između Svetskog udruženja za vaskularno zdravlje i Hispe. Saradnja traje više od 8 godina i za to vreme smo imali 10 zajedničkih kongresa. I veliko mi je zadovoljstvo da najavim profesora Ruvena Cimlichmana iz Izraela i doktora Žira Topušjana iz Pariza, koji će predsjedavati sesijom koja će, siguran sam, biti veoma interesantna sa veoma interesantnim predavanjem. Možemo možda i zapevati posle poslednjeg predavanja profesora Jelakovića, jer je to tema njegovog predavanja. Please.
Dear Nebojša, I'm very grateful from my side and from the members of the society. We thank you for your great efforts that you have done during these 6 years of your presidency, and we visited all Serbia and Republic of SRPSKA from the north to the south. So we are very happy, and ISVH hope that we'll collaborate and we will continue. As I said during the opening ceremony, our Hispa program will spread in other countries, so this scientific project will continue. Okay, my co-chairman is Professor Cimlichman. As you know, you had his beautiful and very rich presentations yesterday, and we'll have another presentation also after our meeting. Okay, so we'll start our session with Professor Vasilis Kotsis from Thessaloniki. Dear Vasilis, we are very, very grateful to you to come personally for only to give this lecture without having the opportunity to visit the beautiful area of, so next time, please come with longer time. Thank you.
It is not working, now it's working. I would like to thank Zirar for this kind introduction, and I would also like to thank the organizers here. I would like to thank my friend for inviting me, and I hope that I will see you all in Thessaloniki next May for the meeting of IVSA there. So my talk is going to be about 24-hour ambulatory blood pressure monitoring. And you can see here that clinic blood pressure measurement has a problem of overestimation of the initial blood pressure measurements. And this allergic reaction is putting this panic button, and you can see here that the first measurement is extremely high, while all the other measurements during 24 hours are normal. And this is the white coat hypertension and the white coat effect. Another limitation of clinical blood pressure measurements is observation bias and digital preferences. You can see here that we are writing down the zero values more times than we are writing the 0.2, the 0.4, the 0.6 values. So this is not proper for the average of the three measurements we are measuring during the clinical blood pressure measurements. Another problem with clinical blood pressure measurements, it is not taking account with increases, transient decreases in the blood pressure during 24 hours. We can see here that we are having peaks, extremely high blood pressure during some time during the 24 hours. At the same time, you can see here that you can have normal blood pressure values. And if the patient is coming to you and you are measuring blood pressure during the evening, then the blood pressure is normal. But you can measure also the blood pressure during the morning, and it is extremely high. So you cannot see the real blood pressure value of a patient. Another problem of clinical blood pressure is the underestimation of the effect of treatment. You can see here that almost 12% of the overestimation of the blood pressure during the measurement at clinic visits can attribute it to white coat effect. So when the patient is treated and he is coming to your office, then you are measuring higher blood pressure than the blood pressure values you are taking during the 24 hours. So you should take into account that some patients are having increased blood pressure values during the visit at the office. Another problem with clinical blood pressure measurements is the limitation of the reproducibility. So 24-hour blood pressure, we are taking more values, we are taking more measurements, and this is making 24-hour blood pressure monitoring more reproducible compared to clinical blood pressure values. You can see here an early study for my group, and you can see in early 2000 that we did 4 blood pressure monitoring studies with 1 month apart them, and you can see that in the same patient, in a working day, the data were similar, and this was the first study showing the reproducibility of ambulatory blood pressure monitoring. On the other hand, the night time is not so reproducible, so other factors can play an important role in the patient's nighttime blood pressure, and this is the problem sometimes with the sleep. You cannot sleep well during some days of the month, and this is causing a not reproducible profile for the nighttime blood pressure. But you can see here, in another study of my group, that when you have the same conditions, these were patients with acute stroke, the first 3 days of acute stroke, you can see here that was a rise in blood pressure during the night time. The first 3 days were similar for the nighttime blood pressure because the patients were lying down, and also the patients are having the same condition of blood pressure measurement. So it is important to know in what condition you are measuring blood pressure during nighttime. From the ambulatory blood pressure monitor, we are getting many information. We can take, you can see here, the average blood pressure during daytime, during nighttime, and 24 hours. We can also take other information like the standard deviation of the blood pressure. The standard deviation is a rough index of blood pressure variability. At the same time, you can have the blood pressure load, the values that are abnormal during daytime and nighttime. And this is important for the target organ damage. Here you can see a normal ambulatory blood pressure monitoring study. You can see that the blood pressure, systolic and diastolic, is normal, and at the same time there is a reduction in the blood pressure during the night time. On the other hand, you can see here an abnormal 24-hour ambulatory blood pressure monitoring study. You can see that the patient is having systolic hypertension. The systolic blood pressure is high, 160 during all day and night. There is no dip during the night time. So we are having a non-dipper patient with isolated systolic hypertension because the diastolic blood pressure values are normal. So a patient with isolated systolic hypertension during 24 hours. You can see here the majority of the information we can get from ambulatory blood pressure monitoring. We can have the average daytime blood pressure values, the average nighttime blood pressure values, and the dipping pattern, as I showed you in the previous slide. And we can also have information about the morning cells. You can see here that in the morning there is an increase in blood pressure. You can see also that we are having also findings for blood pressure variability. You can have the standard deviation of 24 hours blood pressure values and daytime and nighttime systolic and diastolic blood pressure variability. You can see here the normal values for ambulatory blood pressure monitoring. They are 10 millimeters lower than what we had for normal blood pressure values several years ago, 140 to 90 millimeters of mercury. So we are having 130 to 80 for the 24 hours blood pressure, 120 to 70 for nighttime blood pressure, and 135 to 85 for daytime blood pressure. This is going to be changed, I believe, in the future because we are having less values now for the normal blood pressure values for the office blood pressure measurements. You can see where we can use ambulatory blood pressure monitoring. We can use ambulatory blood pressure monitoring in the diagnosis of hypertension, in the diagnosis of white coat effect, in the non-dipping pattern of blood pressure, in autonomic neuropathy, in patients that are having mast hypertension, and you can see that we can use it for the treatment, the treatment results of hypertension and other special issues like in children, in pregnancy, and to have results for the results of for the blood pressure lowering from drugs during 24 hours. Using the two measurements, clinical blood pressure measurements and ambulatory blood pressure monitoring, we can have four phenotypes of hypertension. You can see here that white coat hypertension is increased clinical blood pressure with normal blood pressure values during daytime. True normotension when both measurements are normal. Sustained hypertension when the blood pressure is increased at 24 hours and at clinic. And mass hypertension when you have a patient with normal blood pressure when you are measuring the blood pressure during the clinic visit and you are having an abnormal 24-hour blood pressure monitoring profile. White coat hypertension is an alerting reaction and can affect the most of the patients that are coming to your outpatient office. It is shown that more than 10% to 50% of the populations can have white coat hypertension or increased blood pressure white coat effect during the measurements at office. And it is defined as office elevated blood pressure with normal daytime blood pressure levels. It is more probable to find white coat hypertension when you are having a transient increase in blood pressure from 140 to 160 millimeters of mercury during clinic blood pressure measurements, diastolic of 90 to 99, no evidence of target organ damage, female gender, non-smokers, overweight of obese patients, and limited numbers of blood pressure measurements during clinic blood pressure values. You can see here the importance of age and sex in white coat effect. As you can see, white coat effect is negative in ages from 10 until 30. So the patients are having increased blood pressure values out of office compared to office blood pressure where they are young. On the other hand, when we're aging, the white coat effect is increasing, and also women are having increased white coat effect compared to men. The prevalence of white coat hypertension, as I told you already, is about 10 to 50% of the population. And you can see here in a study for our group again that in patients with obesity, there is increased white coat hypertension compared to patients that are not obese. Here it's 40% in non-obese, 25% in patients that were obese. And white coat hypertension is important, as you can see here from studies from Italy, from the group of Verdechia, that white coat effect can have increased probability, patients with white coat hypertension can have increased probability of having stroke in the following years. Similar results from the Pamela study. Whatever measure was increased, even in clinic or out of clinic, you are having an increased probability of having a cardiovascular disease. And you can see here that the cardiovascular events from a meta-analysis for Fagard was similar to what of normotensive patients, but when you see them in a long-term follow-up, it is not going to be the same factor. So when you're having a patient with normal blood pressure value out of office, then you can define that he is having white coat hypertension. If he is having increased blood pressure, then he is having hypertension. When you have white coat hypertension, then you can see other risk factors for cardiovascular disease, and these probably are increased, and you can have lifestyle modification for your patient. On the other hand, if you find that the patient is having target organ damage or diabetes or other increased risk factors, then you can start blood pressure, you can initiate treatment, especially with monotherapy in these patients when you are having target organ damage and white coat hypertension. This is not the guidelines. This is what we are using in my everyday clinical practice. The guidelines are saying no treatment in white coat hypertension. Mass hypertension is the opposite phenomenon. Normal blood pressure values at office, in repeated measurements, and ambulatory blood pressure monitoring values that are higher than the normal. You can see here in more than 8,000 patients with or without treatment, and they had ambulatory blood pressure monitoring, that we can divide the patients in 4 quarters. The normal blood pressure values at office and out of office, the sustained hypertensive patients, the white coat hypertension, but you can see here there is a big proportion of patients that are having MAST hypertension, normal office and abnormal out of office blood pressure values. This is the factors that you can suspect a patient with normal blood pressure values that can have MAST hypertension. Male sex, younger ages, smokers, normal body weight, transient near the normal threshold values around 130 to 140, what we have was pre-hypertension at the days that I wrote that paper in 2008, several years ago. So it was the pre-hypertension status that you can predict a patient with MAST hypertension. You can see here that you can have more than 10% of the population that are having increased out-of-office blood pressure with normal blood pressure values, MAST hypertension. It depends on the studies and the population, but around 10% of the population is expected to have MAST hypertension. And what is the importance of this phenomena? You can see here that white coat hypertensives have similar with normotensive left ventricular mass index, but mass hypertensive have similar left ventricular mass index with hypertensives, sustained hypertensives, and this is the same results were found in patients in younger ages, in patients with children and adolescents. In children and adolescents, mass hypertensive have similar blood or left ventricular mass index with confirmed hypertensives. The results were similar for intima media thickness of carotid arteries. Mass hypertensive have the same intima media thickness with sustained hypertensive patients, and this is important for the future events that they're going to have. And you can see here that only 24-hour blood pressure values, 24-hour systolic blood pressure value can predict the presence of target organ damage in patients that are having not treated patients that are having increased blood pressure values. The cardiovascular risk in patients with office hypertension in the PAMELA study also showed that when you are having an increase in blood pressure value, you are having a possibility of having target organ damage and a possibility of having cardiovascular events. In the OHASAMA study, similar results. You can see here that white coat hypertension did not reach statistical significance, but again, it was a little bit increased compared to normal blood pressure values. On the other hand, MAST hypertension and sustained hypertension have similar cardiovascular effects in the possibility of having a stroke or cardiovascular mortality in the future. In this study from Finland, they also reported that MAST hypertension is similar to sustained hypertension in the future events in patients that have home blood pressure monitoring for the definition of MAST hypertension. As you can see here, there is a continuum in blood pressure. You can see that the patient with aging is getting hypertensive. But we can see that from MAST hypertension to hypertension, the majority of patients with aging are going to be sustained hypertensives. So we can see it as a pre-hypertensive, but near to sustained hypertension condition. At the same time, white coat hypertensives, the majority of them are going to be evaluate hypertension in the future, so we can see that this is something that is time dependent, and aging is the most important factor for the hypertensive patients. What we know from studies is that nighttime blood pressure is the most important blood pressure value, and you can see here the systolic in Europe hypertension study, and you can see that nighttime blood pressure is the most important factor of predicting 2 years cardiovascular risk. Obesity, at the same time, is an important factor of nighttime hypertension. You can see here that the majority of obese patients are having increased values during nighttime. This is not true for patients with coronary artery disease. You can see here that patients with coronary artery disease have increased lesions in their vessels when they are extreme dippers. So take care of patients with coronary disease not to drop the blood pressure too much during the night time. And finally, I will show you something new about arterial stiffness and ambulatory blood pressure monitoring. This is the primary study we had several years ago, and we want to study in healthy volunteers the probability of having vascular aging inappropriate for your age. So this study had young ages, 20 years old students from the university. We measured pulse wave velocity. We measured also 24-hour ambulatory blood pressure monitoring. You can see here how early vascular aging is defining. This is a time that a patient is having normal blood pressure values, but another patient at the same time having increased blood pressure values. So this is called early vascular aging because there is damage in the vessels of the patients in a particular time of his life. So a patient with 50 years old have increased values of stiffness, and the age of his arteries are for 70 years old. So this is important to know because this is associated with increased probability of having cardiovascular effects. You can see here that arterial stiffness is increased with increased 24-hour systolic blood pressure values, but also with increased 24-hour systolic blood pressure variability. And you can see that only 24-hour systolic blood pressure values could predict the presence of early vascular aging. And we have here home blood pressure monitoring values at the same patients and clinic blood pressure values. So only 24-hour blood pressure monitoring could predict the presence of fever. And this is the values that were associated with artificial intelligence in the forest, random forest model, and you can see that at 24-hour systolic blood pressure, 24-hour diastolic blood pressure, but not home or clinic blood pressure values were associated with early vascular aging. And then we built an application. It is free for you to go there and measure the probability of early vascular aging in a patient you are having 24-hour ambulatory blood pressure monitoring. You should put in this application the sex of the patient, the age of the patient, BMI, the presence of diabetes or not, the GFR of the patient, and the 24-hour systolic blood pressure and diastolic blood pressure values. And you can see that we can have a probability of 0.74 to have early vascular aging in this patient when you are using the data that I have put in this slide. So I would like to invite you in my program in Thessaloniki, the Master of Science Cardiovascular Disease Program. You can do it here from Serbia if you like. It is online. It does not need to be in Thessaloniki, and you can learn many things for hypertension, for lipids, for diabetes, and also for cardiovascular effects of obesity. Thank you very much for your attention.
Thank you, Vasilis. Just a small question, if you have, because we have to leave Vasilis catch his plane. One question. That is, I will ask, to establish masked hypertension, can we use another technique than the 24-hour measurement out of office?
Of course, yes. We can use home blood pressure monitoring, but it's not the same. We cannot define the same patients with home and with ambulatory blood pressure. It is a different population. I don't know why. The majority of them are there, the 60–70%, but not all of them.
Good morning. First of all, I wanted again to express my real happiness to see such a beautiful and large Congress going on with excellent organization. And best regards to Professor Stasic, to his colleagues for this extraordinary work. It's really impressive. We are moving now to the second presentation.
Thank you very much.
And the presenter is Professor Arman Postadian from Sofia, Bulgaria. And his topic is a profile of patients with difficult to control hypertension, blood pressure proaction, BG study. Please.
Thank you, Reverend. First, let me thank Nebojša for the kind invitation to be part of this traditional meeting. Having a speech after Vasilius, it's always a difficult task. So the topic is related with the patient with difficult to control arterial hypertension, and of course we know the diversity of this type of patient. But let me show you some epidemiological data. You know that every year we participate in this International Society of Hypertension program of the May Measurement Month. And in reality, it will not be so fair to compare our own data with the worldwide data, just because the patients are quite different. But if the age of the patient worldwide is approximately 45, so it will be quite good to compare them with the data that we have in our own population. And here you can see that for the majority of the risk factor, we have more profound impact. I even will not touch the question alcohol at least once per week, in which we can see that there is a huge difference between the data of Bulgaria, for instance, versus worldwide. And I think that we have the same problem in our Balkan region related with this topic, which is maybe protective, maybe not enough, but something that it's happened here. Maybe most important part is here, if we see previous infarction or previous stroke, we will see a double incidence of these things. And another, the majority of the patients know they are hypertensive, they are taking medication, but for those taking medication, you can see that the best scenario is to have half controlled and uncontrolled population. So despite taking medication, we have a lot of patients who are not very well controlled. And of course, the new guidelines of the European Society of Hypertension clearly recognize the importance of the patient with resistant hypertension. They put some efforts in order to truly show what are the patients with true resistant hypertension. We have an updated recommendation what should be the medical treatment for these patients, mainly related with the presence of chronic kidney disease, etc., etc. However, we have a lot of gaps. A lot of gaps related with the measurement of the blood pressure, with the risk factor profile, and what we are doing in everyday clinical practice for these patients. That was the reason that we start this program in Bulgaria, which is blood pressure pro-action, just to characterize the profile of the patient with uncontrolled hypertension. We want to have, for a selected number of patients, something related with the blood pressure value, but not only office one, and also introducing out-of-office values, something related with the risk factors, target organ damage, cardiovascular event, therapeutic regimen and the dynamics of the regimen, which is here, and dynamic of the target organ damage and cardiovascular risk. And this is a very short overview. We want to have it as simple as possible. We use, at first step, electrocardiography in order to find ACG sign of left ventricular hypertrophy. We have some measure of kidney function. We have albumin to creatinine ratio, together with the eGFR. We want to have some tests, which in our opinion, it's more easy to use of the practicing physician, not more than 5 minutes, to have some cognition. And of course, another biomarkers that we use of the lipid abnormality, glycated hemoglobin, blood sugar, etc., etc. This is a short study, only 3 visits, 3 months between them. And after that, another set of patients was invited to be in the hospital just to have more sophisticated investigation related with arterial stiffness and echocardiography and ultrasound of the peripheral arteries. So finally, 220 patients, they enter into the cycle and had at least 2 times in a study period out of office blood pressure measurement. Another 120 came into the hospital with this arterial stiffness measurement. More than 25 cardiologists participated in the study. So the ages population is relatively young, less than 60 years, very good representation of the female population inside. And of course, concomitant risk profile is a typical one, 20% of diabetes. Just want to show you that the body mass index more than 30 is present, it's approximately over the half of the patient, smoking in 38% and physical inactivity in 33%. So let me start with the cardiovascular risk because this is crucial. Of course, the first is to see what are the patients with previous cardiovascular event, and you can see that approximately 19% of the people had previous infarction or previous stroke that put them into the category of the very high cardiovascular risk. And another issue is related with the comorbidities that put once again the patient into this very high risk category, and inside is diabetes and chronic kidney disease, and especially the combination of diabetes and chronic kidney disease. And you can see that, of course, those patients are at high or very high risk, so the incidence of previous infarction and stroke in this group of patients is higher than in general population. And last but not at least, what is the recommendation of the new guidelines? Just use score 2 or score 2 all people. Here one remark. In reality, the majority of the physicians don't use this in clinical practice or are prone to underestimate the risk related with the score or score 2. This is a problem in our countries, but you can see that if you use score, maybe you will find some patient at intermediate or even low risk, but if you use score 2 system, the majority of the patients will be at high or very high cardiovascular risk. So the level of the blood pressure are not so impressive. The mean office value are 151 or 90. We included the patient of the office blood pressure between 130 and 140 inside, just because we are not sure that the new European Society of Hypertension guidelines will change or will not change during this time period. And of course, the majority of these patients had also confirmation of the 24-hour ambulatory blood pressure monitoring on controlled levels. So at baseline, 93% of the patients had uncontrolled office blood pressure, and you can see that this blood pressure is uncontrolled also by home or 24-hour ABPM. So something related with the profile, of course, the majority of the patients had uncontrolled blood pressure during the whole 24-hour period. But you can see that approximately 18% of the people had isolated nocturnal hypertension, which is not related with the presence of high blood pressure during the active period. And if we ask ourselves which are those patients who had increased nighttime blood pressure, of course, those are the patients with diabetes, those are the patients especially with chronic kidney disease, and especially in the presence of obesity, which is more prominent here. Related with the dipping status, this is a half-half situation, half deeper, half non-deeper, but we have a significant proportion of patients who are a riser of the blood pressure during the night. So this is another part. And another important parameter that Vasilios talked was this load of the blood pressure. Irrespective of the mean values, at what percentage of situation we have high level of the blood pressure, and you can see that especially for the nighttime systolic blood pressure and nighttime diastolic blood pressure, its increase is approximately 62 and approximately 30% of the people. So the therapy, those are medicated patients at baseline, so maybe a significant number of pills, approximately 3 pills at baseline. What is mistake, however, as a group, as a general, is that you can see that despite having high or very high cardiovascular risk, approximately 30% of the people came on monotherapy. And this is something that continues to be a problem despite all the guidelines that we have. So, of course, the protocol was to have some intensification at the end of the 3-month period. We increased the number of the drugs with approximately 1 drug class, and the majority of the physicians, they prefer to have to give the drugs twice daily versus only 1 time in the morning. Of course, this is not equal for all the combinations. In case that we treat our patient with 2 drugs combination, the majority of the doctors prefer to have fixed dose combination, but having more than 3 drugs, it's quite interesting to see that it's not 3 drugs combination which is preferred. Here is 1 fixed combination of 2 agents and another 1 free agent, which is the preferable option. So related with the drugs, of course, we have all the drugs and all the drug combinations that are available on the market. So this is a successful project. Finally, we have a clear reduction of the level of the office blood pressure, and especially important, reduction also of the levels of out-of-office blood pressure during this follow-up. However, if we change a little bit the perspective and to see what is the uncontrolled hypertension during the follow-up, you will see that despite this therapeutic success, we have a significant number of the people who stay uncontrolled by using this out-of-office technique. And especially for the patient who had a normal office value of the blood pressure, so you can see that uncontrolled based on home or some of the parameters of the 24-hour blood pressure is still here. So this is the masked uncontrolled hypertension based of the use of the out-of-office techniques. Finally, maybe more importantly, we try to have some practical guidance. What is the successful story of this project? And of course, this is the mean age. The majority of the patients are obese, they are at high or very high risk, they have multiple risk factors. And of course, they take 2 or preferably 3 drug combinations, which are those who are recommended by the European Society of Hypertension guidelines. But after that, we must divide, especially the patient with uncontrolled hypertension, and there are 3 types. The first is OBEM expansion. And those patients had high intake of sodium chloride. Those are the patients with chronic kidney disease. Those are the patients with diabetes. The profile of the blood pressure clearly shows a non-dipping pattern or even a riser pattern. They have higher nighttime blood pressure, but also higher nighttime heart rate. And those are the patients who had nighttime hypertension. So what will be the beneficial if we increase the number of the diuretics that we give them? If those patients are not on mineral receptor antagonists, this will be quite successful story. And especially we want to introduce SGLT2 also as a part of the routine treatment of those patients. Another group are the patients with higher sympathetic activity. Those are relatively young people, male or female, with multiple cardiometabolic risk factors. They have higher heart rate during the whole 24-hour period. They have more frequently isolated systolic or isolated diastolic hypertension. And they respond very well on beta blocker, but also on combination with beta and alpha blocker. And this is another part of the drug treatment that we underuse in clinical practice. So we must be more sure that this type of combination will be, it's in reality beneficial in this profile. And finally, maybe the most difficult part are the patients with vascular remodeling. Those are the patients with isolated systolic hypertension. Those are the patients with long-standing hypertension, patients with increased aortic stiffness. If those patients are not on calcium channel blocker, we must give them this. Another part is also the treatment with an alpha blocker and some data that mineral receptor antagonists we have a good beneficial effect. I stop here and thank you for your attention.
question from Professor Neboja.
Yes, it's okay. One question. You said during your presentation that the concept of cardiovascular risk in everyday clinical practice is a little bit underestimated. As I understood, if I understood correctly during one of your slides, which actually I agree, and I think we do not use this risk, and it's actually for the everyday clinical practice. But from your opinion, my question is, what do you think the period between checking the cardiovascular risk should be? 6 months, 1 year, 2 years, in terms of we estimate the cardiovascular risk, we implement some measures, non-pharmacological and pharmacological. Of course, we are doing the follow-up with what we achieved, and then we calculate it again. What do you think in everyday practice for some patient, the time for re-evaluating of cardiovascular risk should be?
Of course, great question. So first, let me say that I'm not quite sure that with this score 2, it's possible in reality. They are not invented just to be so dynamic during the follow-ups. However, we have another tools which give us more good picture related with the lifelong risk. And in this situation, we can use them just to find the progress or to motivate the patient to follow us. Another issue is to implement this as a tool for battling therapeutic inertia, which is also a significant part of the process. If we don't believe of the progress that we must make, related not only with the blood pressure, but also with lipids, etc., etc., so it's not so easy to convince the patient to follow us. So first is our motivation, and those tools are very helpful, and after that, to show some progress of the patient, because another part of the problem is, okay, if you have a patient with past myocardial infarction, you classify him as a very high risk, point. There is nothing after that. If his blood pressure is okay, what are the level, what are the lipids, he will continue to be at very high risk. And he needs something more in order to be inside. And I think we have a good tools here. Full cohort equation give you finally this rich cohort model in patients who have secondary prevention, give you a lifelong risk, which may be used more in practice.
Just one more question. I wonder if you are not applying indirectly, silently, one part of the HISPA program.
So this is in reality HISPA in his idea, and of course this is one of the reasons why International Society of Vascular Health and all of us are here, and every time we enjoy to participate on this meeting, just because we want to have. But another important point is we need data. So in order to be sure that that's happened in reality, we need data. And of course, this type of project is an effort. We will not do this so many times, but just to be sure that it's something good and can be implemented in practice is important.
Okay, thank you very much for your beautiful presentation. And we will move to the next presentation by our friend, Professor Gerard Topouchian from Paris. And the topic is effects of metabolic syndrome on arterial stiffness and prognosis. Please.
Yes. Dear friends, so my presentation will be on the metabolic syndrome, okay, and arterial stiffness. So, but I will come to the metabolic syndrome from another angle. not using of course the waist circumference, but with a new index, body shape index, and concerning the arterial stiffness with something that you know, which is not the gold standard method, but the cardio-ankle vascular index, the CAVI, which is an index of arterial stiffness. So if I rephrase the presentation, it will be the significance of adopting body shape index for the determination of metabolic syndrome in the evaluation of arterial stiffness using the cardio-ankle vascular index. Okay, so I have 4 subjects. The CAVI, I'll say CAVI, cardio-ankle, that you know already. Some of you use the CAVI, especially in Belgrade. So is an index that of arterial stiffness, which is independent of the blood pressure during the measurement. You know that the gold standard is the pulse wave velocity, as index of arterial stiffness, the oldest one. You have 2 points. You put 2 transducers from departure point to the arrival point, and you measure the time. Then the distance you divide by the time, you will have the pulse wave velocity. But CAVI is determined by the stiffness parameter beta that Hayashi proposed, and the Bramwell-Hill equation with the measurement of systolic diastolic blood pressure, and using this all together with the to have the index of cardioangular vascular index, what we say. It is very easy to use. It is done by let's say, you don't need special skills to do. It is operator independent. Just we have to put the electrocardiogram signal, then the heart sound recording, and with 4 cuffs on the upper and lower limbs to measure the pulse wave recording curves and the blood pressures. And you have automatically the CAVI index. So the CAVI index is already established arterial stiffness index, and in many papers, it is reported about the deteriorating factors and improving factors. The deteriorating, as you know, for arterial stiffness, age is the first reason. Then you have atherosclerotic diseases, then coronary risk, as hypertension, you know it very well, obesity, metabolic syndrome, smoking, etc. And the improving factors are when reducing body weight or treatment of hypertension, glucose, etc. So these are things that will take the CAVI, improve the CAVI also, okay? And beside that, moreover, the specialist proposed the cutoff values for CAVI also, as we have for pulse wave velocity, carotid femoral pulse wave velocity, we have 10 meters per second. For the brachial ankle pulse wave velocity, we have 18 meters per second. And for CAVI, we have 9, the index 9 as cutoff point. So if, to summarize, we know a lot about CAVI. We know deteriorating factors, improving factors. We have the cutoff, we know the cutoff, and we know that it's predictor of cardiovascular events. So we'll pass, before passing to the metabolic syndrome, I will speak about the body shape index, which is an abdominal obesity index like other indexes. So I will concentrate on BMI because BMI is the most widely used parameter for obesity as obesity index. So in this study, it was compared the relationship of adjusted CAVI to BMI, adjusted CAVI with age, systolic blood pressure, and cholesterol, with CAVI, with BMI. So it is interesting, this big study with more than 23,000 Japanese subjects, say, the higher BMI, the lower was CAVI obtained in male and female. That's strange, so we call it the obesity paradox. And later, when in another study with about 7,000 Japanese people, the relationship of obesity indexes and CAVI, carotid intima media thickness, was compared, was studied. It was seen that the CAVI was negatively correlated with these obesity parameters, body mass index, fat percentage, waist circumference. It was negatively, while with visceral fat area was positively. And we know that visceral fat area is computed it's measured with computed the tomography, and is the gold standard. No? So from all this, we have to think about these obesity parameters. So there are various types of obesity indexes. So you see BMI, it is cut. BMI, waist circumference, weight to height ratio, body roundness, conicity, and body shape index. We are interested in body shape index because it minimizes the impact of the BMI in the analysis to explain this obesity paradox. So in this case, in this population, 62,000 Japanese population, the body mass index was compared with other obesity indexes. So strangely, only the body shape index was positively, was strongly correlated, not correlated with the BMI, while the others were correlated. So continuing in this direction, in the same population, the correlation between body shape index and conicity index was compared, and there was a strong correlation. So the authors of this paper think that there is correlation, strong correlation between conicity index and body shape index, and mathematical formula is convertible. So, and they say the body shape index is a variant of conicity index, not affected by the obesity paradox. So for that reason, they continue their studies in the direction of these parameters with CAVI and renal dysfunction. So they compare the body shape index, all the obesity indexes with CAVI, high CAVI. You remember that CAVI cutoff is 9. Okay, people having high CAVI, and they compare also the renal dysfunction. So here they find that only body shape index was really correlated with this high CAVI and renal dysfunction, and the cutoff value was about 0.08. This value was obtained and suggested by Krakauer, who first time discussed this body shape index and found that there's a mortality risk with body shape index higher than 8. Okay? So this cutoff point was confirmed by the Japanese investigators, while when they compared the other obesity indexes, you see that here they have U shape, while this was a linear shape. So this also spoke about in favor of the importance of body shape index. Again, when they studied the relationship of CAVI with these obesity indexes, BMI, waist circumference, and body shape index, and studying by tertiles of this population of these parameters, indexes, and compared to adjusted CAVI with age, systolic blood pressure, and cholesterol, they found that the correlation of CAVI was negatively with waist circumference and BMI, while the correlation was positive with the body shape index. See? And they came to a conclusion that those parameters, the BMI-dependent indexes, are influenced by this obesity paradox discrepancy that we have, and the other indexes that are not BMI-dependent will be better and not influenced by the obesity paradox. So we'll go now, we'll pass to the metabolic syndrome, because there are also contra-arguments in several publications. Because some of them say that there are many non-metabolic syndrome patients who are clearly at higher risk of cardiovascular disease than metabolic patients. For example, the second one, metabolic syndrome does not necessarily predict cardiovascular disease risk above and beyond its individual component. So elevated waist circumference is associated with chronic kidney disease to a less extent after adjusting, etc., etc. So there were some publications with these counter-arguments. And people, Nagayama especially, started to think of what could be the reason, because he thinks that one of the criteria that is used in the definition of the metabolic syndrome could be the reason. And you see that in different formulas, definitions, you have always the waist circumference with different values. And they wanted to replace this waist circumference with body shape index, with the cutoff value of 0.08. And applying this on studies done with CAVI, the analysis done with metabolic syndrome diagnosed with waist circumference and compared to CAVI, there was no difference in using this, even three formulas, three definitions. While applying the metabolic syndrome definition with body shape index, the CAVI analysis with these formulas gave significant, was strongly significant. So they continued and made Kaplan-Meier curves to study the progress of functional decline over 4 years with metabolic syndrome patients, with and without metabolic syndrome patients. When they applied waist circumference in the definition of metabolic syndrome, there was no difference. But when the metabolic syndrome formula definition, in the metabolic syndrome definition was used body shape index, you see that was strong, significantly difference between this metabolic and non-metabolic patients. The decline was very strongly. So this was the studies done by the Japanese in different other studies. It was applied by Shirai. Professor Shirai was one of our friends, ISVH member, and one of the investigators, let's say, principal investigators of the AAA study that we have published. When we made the first analysis, CAVI and metabolic syndrome and pulse wave velocity and metabolic syndrome, with pulse wave velocity, there was significant difference between metabolic syndrome patient and non-metabolic syndrome, in men and women, while with CAVI, there was no difference. When we used, before using, then it was, Shirai analyzed also BMI and waist circumference and body shape index in the AAA population. We had 2,000 patients, and after cleaning, it stayed only 1,700 subjects. So the CAVI compared to BMI and waist circumference was negatively correlated, while with body shape index, it was positively correlated. And when it was applied on the metabolic syndrome formulas using the NCEP and IDF definitions, you see that here we have the CAVI compared to metabolic syndrome with waist circumference, the blue one, and body shape index with the red one. You see that with body shape index, CAVI is strongly, the result were strongly significant. So we came to that conclusion that in these studies, in the big population study, and even our own study, when metabolic syndrome is defined using body shape index instead of waist circumference, CAVI showed higher value in patients with metabolic syndrome among both Japanese and European, the AAA studies. Okay, and the use of body shape index instead of waist circumference for the metabolic syndrome diagnosis may be effective to identify subjects at risk of increased CAVI and renal function decline. So I will finish with the acknowledgement to Professor Shirai for his work, Professor Roland Asmar, and the AAA study members, investigators, Professor Boyan, Anna, and Professor Tazic for this excellent study. And to finish, I'll say that the second paper of AAA is just submitted, and we have almost accepted. It remains small comments to give, and the publication will be soon. Thank you.
Thank you very much, Girard. Do we have questions or comments to Professor Girard? Okay, thank you. And the next presentation.
Professor Bojan Jelakovic from Zagreb will play, music and hypertension.
Yeah. Thank you, Gerard. Thank you, Ruben. First, I have to apologize to both of you because I will not speak in English. The slides will be in English, but as we are here at home, I will speak in our language. So, sad ću okrenuti na naš, drago mi je što sam ovdje, hvala Nebojši na pozivu i isprika moja na ranijim odbijenicama, ali uvijek se nešto preklopilo, pazit ćemo da se to u buduće ne događa. Evo, moja tema je muzika i fire. Bilo mi je drago, doći ćemo opet. Dakle, evo, dobro je. Da. Prvo je mrak, u početku je bio mrak. I u mraku je bila tišina prije velikoga praska što je nastao u svemiru i onda, kako kažu, u početku bjaše riječ, jel tako, za većinu ili velik dio ljudi na kugli zemaljskoj. I onda je nastala buka kad su ljudi počeli pričati, raditi, komunicirati i međusobno se svađati. Koliko je ta buka važna, to je prepoznato već odavno i Svjetska zdravstvena je to uvrstila zapravo kao jedan od bitnih faktora kardiovaskularnog rizika i u novim smjernicama Europskog društva za hipertenziju to se nalazi kao jedan vanjski faktor koji snažno utječe na kardiovaskularni rizik i nastanak hipertenzije. I ovdje vidite podatke iz 2014. koliko se novonastalih hipertoničara pripisuje buci i koliko je bilo prijevremenih smrti pripisano ili povezano sa bukom. Dakle, to je važan faktor rizika, pogotovo u velikim gradovima gdje je to ponekad i nesnošljivo. Zato se u engleskom i ta buka dolazi od riječi nauzea, jel da, bolest, to je nešto što nije zdravo. Sad, oponent tome je nešto što je lijepo, nešto što čovjek stvara i to je muzika. I često viđamo na našim saobraćajnicama ljude mlade kako hodaju sa slušalicama na ušima kako bi se spriječili te buke. I jučer ste slušali predavanje profesora Zimmelmana o harm reductionu. I sad pitanje je koliki je to harm reduction kada neko umjesto da čuje buku na slušalice stavi i sluša neku vrstu muzike. Ali to je pitanje da pravi harm reduction ili to povećava rizik saobraćajke. Prema tome nije baš pravi harm reduction. No, s druge strane isto vidimo često mlade uglavnom da trče sa slušalicama u ušima i dok trče bave se fizičkom aktivnosti, slušaju nešto dobro i to je nešto što je u redu. Jer Platon je rekao u svojoj Republici, muzika i sport su dva temeljna aspekta zdravlja. Dakle, to se može shvatiti kao nešto dobro i to je nešto opet što je ušlo u ove nove smjernice, zapravo taj mindfulness ili posvećenost trenutku i sebi samome. Dakle, ovdje se na dva načina posvećuje sebi samome, jel da jedno je tjelesna aktivnost, fizička vježba, a drugo je slušanje muzike i utonjavanje u sebe, u svoju bit i razmišljanje i opuštanje. Dakle, mogli bi reći muzika nije bijela, ona je plava i koliko ona važna, već odavno bilo prepoznato, vidite u srednjem vijeku je ona ušla u ove temeljne neke tada discipline naučne, pa je s aritmetikom, geometrijom i astronomijom bila i muzika. Kasnije tome priključena gramatika, logika i retorika, dakle uvijek je muzika bila jako važna za ljudski rod. Dakle, jer muzika odjednom je sve postalo šareno i može biti dobro kao što je sinoć bilo. Kad sam se ja prvi puta susreo sa ovim malo problemom dublje, to je kad sam organizirao ljetnu školu Europskog društva za hipertenziju u Rovinju, onda je jedan od predavača kojeg sam pozvao bio Peter Slide, pokojni nažalost, veliki stručnjak i on je pred kraj svoga života odlučio malo se posvetiti istraživanjima toga, muzike, jer to mu je bila očito ljubav i obsesija kroz cijeli njegov život. Do tada meni je povezanost muzike sa nečim biološkim bila ona priča o Mozartovom efektu na krave muzare. Pa je bilo rečeno ako krava sluša Mozarta, onda će davati više mlijeka. Međutim, to znamo da nije baš tako i već onda je Peter Slide rekao da je to više priča za malu djecu, mit, nego prava znanost. Sad relativno nedavno sam naišao na ovaj članak kada su proučavali učinak muzike na krave muzare. Ali sad su oni htjeli zaista dokazati istraživački da li postoji kakvih povezanosti, da li je to priča ili nije. I onda vidite, tu su oni uzeli 20 krava i puštali su im raznu vrste muzike i gledali su da li to povećava produkciju mlijeka kod njih. Valjda su to Amerikanci htjeli napraviti da možda malo više zarade, ali to u kapitalističkom svijetu nije ništa neobično. No ono što je bilo iznenađenje, krave su bile najproduktivnije u tišini. Dakle, vole mir u svojoj štali i nema toga. Drugo što je bilo, bilo je uspavanke. To je uz uspavanke isto tako bilo. Onda oni su puštali, vidjet ćete malo kasnije, raznu vrstu muzike i vidjeli su ne reagira svaka krava na istu muziku, kao ni svaki čovjek, ali nekom se sviđa ovo, nekome ono. I onda, evo vidite, ovo što sam rekao, najviše je bilo uz tišinu i uz uspavanke. Ja sam mislio da će biti, kako su krave, da će biti country muzika, da su to kaubojke, krave kaubojke, da će uz country muziku davati najviše mlijeka, međutim, zeznuo sam se, nije baš bilo tako. Ali ono što je, vidite, uz heavy metal, većina krava nije volila heavy metal. Jedna krava je volila, uvijek ima neka krava koja voli heavy metal. Onda, ono što sam mislio da će biti malo bolji učinak, to je bila opera, ali nije ni opera baš tako jako pozitivno djelovala na krave, ali kad su puštali klasičnu muziku, onda vidite tu je većina krava se opustila, a 50% krava čak počelo preživati. Dakle, počelo je preživati i to je ono rest and digest, to je parasimpatikus. Dakle, to je pokazatelj da se kod tih krava aktivirao parasimpatikus, jer aktivacija parasimpatikusa, kao što ćete vidjeti kasnije pravo objašnjenje kako muzika povoljno djeluje na kardiovaskularni sistem. Koliko je sad muzika već ušla duboko u to, evo, prije nekoliko godina NIH je odobrio jedan vrlo veliki projekt, nekoliko milijuna dolara. Tu je bila, u ovome projektu je uglavnom bilo fokusirano na neurološke bolesti, što je i logično, jer muzika prvo aficira mozak, a onda nakon toga sve ostalo. Postoji čak svjetsko udruženje za liječenje muzikom i onda ovdje možete vidjeti koja je definicija zapravo terapije muzikom i to zaista ako želimo da bude prava, mora biti profesionalna. Pitanje sad da li to može raditi neko samo ko je muzičar, a da nije baš i medicinar, vjerojatno je to nespojivo i nemoguće, jedino ako nije neki priučeni muzikoterapeut. Ali uglavnom postoji opravdana potreba da se ta muzika primjenjuje za sve aspekte našeg života. Kao što znamo, većina ljudi, to je nasušno potrebno da slušaju muziku. E sad, kad je to krenulo, muzika i medicina ili muzika kao medicina, pa onda svi znamo za Apolona. To je prva figura u ljudskoj povijesti koja je objedinila i muziku i medicinu u sebi. On je bio bog muzike i bog liječništva. Prema tome, to je pokazatelj koliko su Grci onda u antičko doba pripisivali puno važnosti muzici. Ali ne samo ovdje na Europi, nego je, vidite, u Kini, u kineskom pismu, znak za muziku nalazi se u znaku za sreću i u znaku za medicinu. Dakle, i na Dalekom istoku to je isto tako bilo kao i u drevne Grčke. I onda, kad malo istražujete literaturu, onda vidite prvi članak publiciran o povezanosti muzike i utjecaju muzike na tlak i na EKG je još 918. Dakle, još je Prvi svjetski rat trajao. Dakle, već za vrijeme toga je objavljen taj prvi članak i ovi autori, Heidi Scalapino, su gledali različite vrste muzike, kako djeluju na ljude koji imaju ili nemaju neke posebne veze sa muzikom i oni su analizirali jednu sporu, melankoličnu, pomalo tužnu melodiju od Čajkovskoga, onda su analizirali iz opere Carmen jednu veliku, vedru, veselu, dinamičnu i treća je bila kompozicija, to je bila američka himna. I onda što su vidjeli da se to malo razlikuje isto učinku na tlak, na sistolički i na srčanu frekvenciju. I ono što su zaključili, one tužne kompozicije kao što je ova od Čajkovskoga je zapravo bila povezana sa porastom pulsa, frekvencije srčane i padom tlaka, a s druge strane marš toreadora iz Bizeove Carmen je bio povezan sa porastom tlaka i oni su zaključili zapravo da melodičnost i dinamičnost kompozicije utječe na to, međutim to nije točno, ali vidjet ćete kasnije, bitan je ritam. Ritam je ključan koji određuje kako muzika utječe na naš vegetativni živčani sustav. Malo je toga rađeno, malo istraživanja i onda vidite ovo je 2023. jedna meta-analiza 20 randomiziranih kliničkih pokusa sa 2300 otprilike bolesnika i pola od njih je slušalo muziku, pola od njih nije. I šta su vidjeli? Zapravo da ima učinka u toj meta-analizi na tlak i da je došlo do pada sistolički za 9, dijastolički za 6 i kad neki od antihipertenzivnih lijekova napravi takav učinak, mi smo već zadovoljni. Jel tako? Ako nismo zadovoljni, onda ako uz muziku možemo to ostvariti, onda ćemo nešto i uštediti. Jer ćemo moći pripisati jedan lijek manje, veća adherencija i u konačnici bolja kontrola. I ono što su oni zaključili, dakle, to je džaba skoro, jel da ništa ne košta, lagano je uključiš, isključiš, nije invazivno i, kao što sam rekao, smanjuje troškove i preporuka da se to koristi kao adjuvantna dodatna terapija kod bolesnika sa hipertenzijom, a i sa svim kardiovaskularnim rizicima. I onda je pitanje, opet kao kod krava, vredi isto kao kod ljudi, pa su puštali razne vrste muzike i onda gledali zapravo kako ima taj učinak. I onda su tu sada u ovom istraživanju puštali Mozarta, jel da razvije onaj mit ili potvrde mit sa mljekarstvom, Straussa i Abu. Jel da, to su sad gledali dvije kompozicije dva kompozitora iz prošlosti i ova grupa iz 20. stoljeća. I šta su vidjeli kad su puštali Mozarta i Straussa, došlo je do pada oba, i sistoličkoga i dijastoličkoga, ali iznenađenje sa Abom to nije postignuto. A svi znamo kako Aba ima fine kompozicije, osvojili su Eurosong ono davno prije sa Waterloom i ono je tu bilo otprilike kao tišina. Isto tako nisu vidjeli niti razlike u spolu, u dobi, bilo čemu drugome i nisu vidjeli tu baš prevelike razlike niti u kortizolu, osim što opet kortizol kao hormon stresa bio najmanje smanjen ipak uz tišinu i bio je nešto niži uz Abu nego uz Straussa i Mozarta. I sad šta razlika od Abe? Pa Aba ima riječi i to je pjevano. I te riječi djeluju na druge sfere u mozgu i ne djeluju na onaj vegetativni živčani sustav, djeluju na naš frontalni korteks i tu mi počnemo onda razmišljati neke asocijacije, vamo tamo, nekome dobro, nekome loše i zbog toga nije vjerojatno te kompozicije koje imaju riječi nisu jednako dobre kao kompozicije bez riječi, a slično se dogodilo i sa kravama, jer krave kad su slušale operu, jel da one ne razumiju, ali očito je to, taj ljudski glas u tome njima malo smetao i ipak je bilo bolje kad nisu slušali operu. I sad što je bitno da bi neka muzika djelovala povoljno, to je da ima ove neke elemente, to je najbitnije ta periodičnost, da se nešto stalno repetira, da se ponavlja i da to prati, da je to jednostavno, da nije komplicirano i da ima zapravo dobru harmoniju. I sad idemo opet na drugi kraj svijeta da vidimo, jer to vrijedi, ovo su sve bile zapadnjačke civilizacije, zapadnjački kompozitori i Strauss i sve ove koje sam spomenuo, šta je sa Indijom? Dakle, znamo da je indijska medicina i ovo je sasvim drugačije i u vedskoj medicini i općenito u vedskoj filozofiji postoje 7 nekih temeljnih bazičnih tonova koji su povezani sa 8 bazičnih raspoloženja prema indijskoj filozofiji i indijskoj medicini. I onda u indijskoj medicini kada se koristi muzika postoje nekoliko raga. Ima dvije vrste bazične njihovih kompozicija, jedna je raga i te su rage korištene uglavnom u smislu liječenja. Ima čak nekih raga koje su posebno komponirane da snižavaju tlak. I odite na YouTube pa ćete naći te neke rage, meni je digalo tlak, nije snizilo, ali to je druga kultura, ja ne volim kad tako ono nešto zavijaju tamo. Ali njima to djeluje. I to je taj pristup u te vedske medicine, oni su to nazvali odabir te muzike pravi gestalt. Dakle, prema svakome ideš sa onom i to opet vraćamo se na smjernice, na taj mindfulness koji je isto ušao u smjernice Europskog društva za hipertenziju. I kad se sad predaje, opet kad misli se na Indiju, na muziku, onda je opet asocijacija joga. I onda vidite, joga je, majstori te joge su povezali svjetski dan joge sa svjetskim danom muzike. I ono što je važno, tu su rekli poveznica između disanja i ritma. To je ono što je bitno što nam joga donosi uz smanjivanje respiracija, tako smanjuje se frekvencija. I sada vidimo, to smo mi nekada davno, svi smo ovako izgledali i prvo što smo mi čuli smo ritam otkucaja srca naših majki i zato se i djeca kad se rode lakše umire na prsima majke nego na prsima očeva jer čuje onaj poznati ritam. Drugo, ljudi, a vidjeli ste ranije krave, imaju nekakvu sposobnost da love te vanjske ritmove i adaptiraju se na neki način tim ritmovima koje svi slušamo i zato je ta buka koja je loša i tako pogubna za kardiovaskularno zdravlje. I sada kad govorimo o hipertenziji, o kardiovaskularnom sustavu i o zapravo tom vanjskom utjecaju i brzim promjenama, tu su ključni baroreceptori koji djeluju onda na centralni živčani sustav i preko njega se manifestiraju vrlo brze promjene, se mogu ostvariti na dva načina. Jedno je simpatikus koji ide sporo, koji dovodi do periferne vazokonstrikcije i do porasta i pada tlaka. Drugi je brz, to je vagusni krak koji djeluje na srčanu frekvenciju. I to je ta nedovoljna perfekcija tog vegetativnog živčanog sistema i zašto je to tako napravljeno, vjerojatno neki dublji razlog postoji. Uglavnom, to je tih 10 sekundi se to međusobno lovi, to se nazivaju takozvani Mayerovi valovi koji su karakteristični za svaku vrstu. Svaka vrsta, pa tako i ljudska vrsta, ima te Mayerove valove i kod nas to traje tih 10 sekundi, odnosno 6 ciklusa u minuti. 6 ciklusa u minuti se to ponavlja, šta god mi radili, ležali, stajali, sjedili, to je nešto temeljno što nas drži da zapravo možemo normalno funkcionirati i to je sporije nego frekvencija respiracije. Dakle, ono što je važno isto primjećeno je da baroreceptori, jer to je kratka regulacija tlaka, primjećeno je da baroreceptori mogu djelovati dugoročno jer djeluju na reapsorpciju natrija u proksimalnom tubulu, dakle na taj način reguliraju dugoročno krvni tlak i dugoročno mogu djelovati na hipertenziju. No važno je da zapamtite ovih 10 sekundi za nastavak ovog predavanja. I sad, kad mi slušamo muziku kao i sve drugo, koji ima ta urođenu nagon ili potrebu ili sklonost da lovimo vanjske ritmove, onda i kad slušamo muziku, onda očito je i vjerojatno ćemo i loviti ritam muzike. I sad onda je pitanje može li muzika utjecati na srčani autonomni sistem i opet jedna meta-analiza, opet nema puno istraživanja i to je glavni problem sa time. Dakle, vidite, 29 je samo bilo studija, 1300 ispitanika. I ono što su oni uočili i koje su rezultate dobili, da muzika zaista djeluje na autonomni živčani sistem i to tako da povećava aktivnost parasimpatikusa, kao što se dogodilo kod krava rest and digest, tako isto je ovdje opođeno da raste varijabilnost srčanog ritma, a to je ono što želimo, što je povoljno za razliku od varijabilnosti tlaka koji, kad je što je veća varijabilnost, to je gora prognoza. I sad se vraćamo do Petera Slajta i do tih istraživanja koje je on radio kada je već bio pred penzijom ili skoro je bio u penziji. On je otišao u Italiju i tamo je našao svoga prijatelja koji je imao isti interes kao on i onda su analizirali 12 muzičara i 12 ne muzičara i puštali su im razne vrste muzike, pa su pustili Puccinija, Turandot, Beethovena, pa Bacha i Verdija sa nekoliko njegovih sjajnih opera i puštali su ih da sjede u tišini. I onda su analizirali ove parametre koji su dolje navedeni kardijalne hemodinamike. I onda koje su razlike između tih kompozicija? Prvo, Bach je intelektualna, to je matematički praktički kompozicija. Turandot to je emotivna kompozicija, strašno nabijena i vrlo dinamična i zapravo potpuno vas okupira emotivno. I onda Verdi, Nabucco, to znamo da su to pjevne kompozicije i ono što je razlika između Verdija i ovih, vidjet ćete kasnije, kod Verdija se njegove arije imaju taj ritam od 10 sekundi. Od 10 sekundi to jedino ima kod Verdija u njegovim operama. I onda kad gledate sada ovog Bacha, dakle dolazi do blagog porasta tlaka i nakon toga dolazi do vazodilatacije i do blagog pada krvnog pritiska. Kada gledate Puccinija, opet dolazi jedan crescendo u muzici, dolazi prvo do skoka tlaka i onda do vazodilatacije i do blagog pada tlaka. A onda kod Verdija u ovom ritmu od tih 10 sekundi, ti Majerovi valovi su ulovljeni ovdje, skok tlaka i onda zapravo nakon toga pad tlaka, ali što je važno, dolazi do tahikardije i do porasta variabilnosti srčanog ritma, što je jedino opaženo uz Verdija, dakle niti uz ovo jednoga, niti uz drugoga. Onda su ih dalje pustili da sjede. Sjede ko onaj vic o muji što radi sjediš i radiše, majok samo sjedi. Vidjet ćete da to što samo sjedi i djeluje na autonomni živčani sustav, što je razumno. Onda su opet pustili Beethovena i na kraju su opet pustili Verdija. Evo ovo sjedi i fino se opusti i to je dovoljno dobro, smirimo se, ali tlak malo padne, 2 do 3 mm. I onda kad su pustili Beethovena, isto lagana muzika, fino te odnese negdje sa mislima, dolazi do vazodilatacije, tlak malo više padne, 10. I onda opet Verdi, opet druga kompozicija, opet taj ritam Majerovih valova, vazodilatacije i opet heart rate variability. I sad su zaključili, taj Verdi ipak je nekog vraga ulovio, znao on to, ne znao, slučajno napipkao i vjerojatno zato tako bio omiljen u Italiji u 19. stoljeću. Dakle, ono što su tu zaključili, to je neovisno o respiracijama, to je jako važno za reći. Dakle, to je pokazatelj da muzika djeluje neovisno o disanju na autonomni živčani sistem i rekli su zašto to ne bi bila dobra podloga, imamo sada objašnjenje koji mehanizam da ta muzika zaista djeluje povoljno, svaka, a ova Verdijeva pogotovo. Onda kad su analizirali srednje vrijednosti, ovdje vidite usporedbu kako se kretala kompozicija i kako su skretao te promjene u autonomnom živčanom sistemu, vidite prosjek 12 muzičara, kroz svih je to bilo isto. Onda su gledali 24 i muzičari i ne muzičari, kod svih je to isto bilo. I onda se postavilo pitanje, je li Verdi bio neurofiziolog, kako je on mogao to znati? On je vjerojatno to nije znao, nego je to tako osjetio, zato je tako bio genije. Genije ne može nikad objasniti kako on to zna. On to zna, napravi progres, a drugi onda to trebaju dalje istraživati i objašnjavati. E sad jedna druga priča zanimljiva, nije muzika, ali se nadovezuje na muziku, nadovezuje se na ovaj ritam od 10 sekundi. To je priča o molitvi krunice u crkvama, izgovaranja mantri opet u indijskoj religiji, jel, tako dalje. I sada ta krunica što se moli po crkvama, u katoličkim crkvama, kad se govori 50 puta ponavljaju Ave Maria. I to moraju ponavljati 50 puta na latinskome, da ima neku važnost, ako govori na bilo kojem drugom jeziku nema, jer na latinskome to se ulovi taj ritam od 10 sekundi, jer svaki puta kad se to kaže, onda to se ponovi to što se treba ponoviti, onda prođe 10 sekundi. I onda je to su taman tih 10 sekundi Majerovi valovi. I onda su ova Peter Slajtova grupa išla to istraživati. Išla istraživati Majerove valove, da tako kažem, kod onih koji mole krunicu i onih koji ponavljaju indijske mantre. I što su vidjeli? I mantra i krunica je usporila disanje, to kao što gore vidite. Dakle, za razliku od muzike, to je išlo putem usporavanja respiracije, to je ono što radi joga. Dakle, i onda je to djelovalo povoljno na baroreceptore, došlo do pada tlaka, ali nije došlo toliko jako do promjene srčanog ritma. E sad, koja je povezanost između te Ave Marije i mantri? Pa kad su križari bili na istoku i tamo pljačkali i uništavali, onda su zapravo oni od Arapa, koji su to preuzeli od tibetskih svećenika, preuzeli tu mantru i uvrstili je u svoju liturgiju. Dakle, i sada je pitanje, to nije ta sličnost i povezanost između jednoga drugog koja je ovdje dokumentirano, to je vjerojatno objašnjenje toga da se ta indijska religijska praksa pretočila u kršćansku. I onda to moljenje krunice, to nije samo očito vjersko, nego može biti i korisno za zdravlje. I onda su autori zaključili da je to zapravo vječna neka životna poruka, moliti Ave Mariju i to je povezivanje nas sa Bogom, to je jako religiozno, pa sam ja to zamijenio da je to znanost povezana sa prirodom, jel da? To je onda ono što je pravilnije za reći. I zanimljivo kad gledate na Hannes, veliko američko istraživanje, onda su oni vidjeli, oni koji redovito idu u crkvu, oni imaju niže krvni tlak. Jel? Sad je to pitanje da bi svi trebali ići tamo. Pa ne bi, jer neko je našao spas i Boga u crkvi, neko je našao u poeziji, neko je našao u meditaciji, neko je našao u jogi, neko je našao u slušanju neke vrste muzike. I ovo, znate vjerojatno neki iz kojeg je to filma, zapravo je Sound of Silence is music to the heart, jel, to je vraćanje nazad onom što treba, ili kako ovaj drugi rekao, nemoj pričati ako ne možeš poboljšati tišinu, jel, bolje šuti nego ne blbeći. Dakle, tu u početku je bila tišina i onda je bila muzika. Sada ima još puno toga što nam ne dozvoljava da to bude evidence-based, da to na temelju toga mi kažemo da i sad ćemo napisati recept za muziku. Nema dovoljno naučnih dokaza, ne znamo koja muzika je superiornija, ja sam pokazao, ali to opet vidjeli ste je vrlo individualno, dakle to će trebati uvijek tražiti individualni pristup i to je vjerojatno će biti tako ispravno. Ponudi mu Verdija za kojeg znaš da ima utjecaj na živčani sistem i na kardiološki hemodinamiku, ali ako ga ne voli, nema ga tjerati, nego pusti ga da sluša nešto drugo. Onda treba vidjeti kako to primjenjivati, koliko dugo slušati tu muziku i ovo što je za svu medicinu važno, to je taj individualni pristup. Ali ono što je bitno, opet se vraćam na onaj zaključak, to je jeftino, to je jednostavno, nije invazivno i može nam smanjiti troškove jer ima dokaza da slušanje bilo koje vrste muzike snižava pritisak za 9/5 mm žive, što je značajno. Dakle, i treba ne to biti jedina terapija, monoterapija, nego treba biti dodatna terapija, a kao što je rekao Hipokrat, s time nikome ne štetimo, osim ako ga ne tjeramo da sluša neku muziku koju ne voli. I završću sa ovim, to je stari jedan film, odličan, kaže tko pjeva zlo ne misli. Svako ko voli muziku ne može biti loš. Evo i nekome ne može biti loš ako je prava muzika za njega odabrana. Evo, hvala na pažnji.
Thank you, Bojan. Very interesting, not inhabitual presentation, and the conclusion was very, very good. Everything explained.
Okay,
Professor
I'm
Tazic.
sorry for Arman, Ruven, and you. I asked him to speak in his language because of the audience, to understand it better, and he can show the devil is always in details. So he showed a lot of details, and it's really inspiring lecture. My question: why nobody investigated mans and cows in the same time with the same music to see the differences?
We can do this here in Bijeljina, maybe some
yes,
villages.
Okay, just to thank you. The lecture was really perfect.
I have one comment. Years ago, we did some studies comparing effect of music and rhythmical musical sounds on blood pressure. And there are about 6 or 7 publications. 2 of them are ours in the field. And we have shown that music lowers blood pressure, as expected. However, if you create series of sounds which are rhythmical, and you ask the patient to breathe according to the rhythm of the sounds, the decrease in blood pressure was maybe two times more than just regular music. And then a company developed a device that you can buy on the internet. It costs, I think, $100 or something. And if you train at least 4 times a week, 30 minutes, you just have to relax, put the headphones on, and listen to the music, to the rhythmical sounds, and trying to breathe slowly with the rhythm. And the results are really impressive. So here we have the connection with the obstructive sleep apnea, not allowing the blood pressure to go down during sleep. And when you improve the rate of the breathing connected with music, there is something in it for the future to develop, to help people.
Yeah. Thank you, Ruven. Sure, breathing even more emphasize this effect of music because there are 2 rhythms which then goes hand to hand.
So it's a very, very interesting topic. All right.
Okay, I would like to conclude the session and to ask everybody for a coffee break, and we continue in 11:30.